in Greece, we have established the SOE session that it will include the lecture of International Council of Ophthalmology, President of SOE, SOE lecturer, and after, rapid-fire presentation for young ophthalmologists. Finally, we establish this in every Congress we have this session. So, Professor Kozobolis, go on.
Thank you very much. I would like to invite Dr. Panos from University Clinic of Geneva. Dr. Panos was partially trained in our clinic, and I'm very happy to welcome. And Dr. Panos, you have 4 minutes.
Thank you very much. Good evening, dear colleagues. It's my pleasure to join you here in Thessaloniki. I would like to thank the organizing committee and especially the President, Dr. Kozais, for the invitation. I will present you a study entitled 10 Years Incidence of Retinopathy of Prematurity in Low Birth Weight Newborns in Geneva. As you know, retinopathy of prematurity, ROP, affects mainly very premature infants. It's one of the main causes of childhood blindness worldwide, and the recent literature on incidence shows variable trends. This variability can be explained by the different populations, medical and nursing level, the period of observation, and the observer himself. Studies showed in the United States of America that the incidence of ROP in low birth weight babies was 81%. On the other hand, in Germany, this incidence was only 31.5%. Of course, the main risk factor is prematurity, especially gestational age below 32 weeks, birth weight less than 1,500 grams. Among the other risk factors, the most important are high oxygen administration and repeated oxygen desaturations. I will skip the theory, I think that you all know that. Our study was a single-center retrospective non-comparative study. We included data from our neonatology unit in the University Hospitals of Geneva of the last decade. All premature babies with a birth weight less than 1,000 grams were included in the study, with an ROP screening proceeded up to at least 37 weeks gestational age. 305 patients were included, 194 survived, total survival rate 64%, male to female ratio 1 to 1.3, mean gestational age 27 weeks, mean birth weight 870 grams. The overall ROP incidence was 40.7%, but the incidence of threshold states, the states which requires treatment, was only 5.15%. In this table, I show you the incidence of different ROP stages. Thank you very much. And as you can see, the stage 3, threshold stage 3, which requires treatment, was very low. Only 10 babies required treatment, and only 1 baby developed a more advanced stage with retinal detachment. In these bars, we see the distribution of different ROP stages according to birth weight and gestational age. As you can see, the distribution was comparable for both factors. This slide is very important. In this slide, you can see the results from different centers. In European cities, the incidence of ROP was significantly lower compared to other centers. Especially Geneva, together with Utrecht, have the lowest incidence of severe ROP worldwide. In our study, none of the patients with a gestational age more than 28 weeks developed a stage 3 disease. Statistical analysis showed a correlation, negative correlation between gestational age and ROP stages 2 and 3, no correlation between ROP stages and birth weight, and a positive correlation between ROP stages and mechanical ventilation. Among the 3 major risk factors, gestational age, birth weight, and mechanical ventilation, gestational age below 28 weeks was found to be the most important. The factors which contribute to this low ROP incidence in Geneva where are low oxygen administration compared to other countries, and especially individualized therapeutic protocol for oxygen saturations. In Geneva, we have one nurse for each patient, 24 hours per day, close observation, 7 days per week. So we have the possibility to stimulate mechanically the children instead of increasing the oxygen supply. This is very important. In conclusion, ROP morbidity for stages 2 and 3 shows similar distribution regarding gestational age and birth weight. In our study, incidence of threshold stage, which requires immediate treatment, was low compared to other studies. In low birth weight babies, gestational age of less than 28 weeks was a significant predictor for development of ROP stages 2 or 3. I would like to thank you for your attention, and I look forward to our next meeting.
Thank you so much, Dr. Panos. I would like to ask Dr. Kopsidas from Moorfields Eye Hospital to come up. And I would like to tell you to stay at the end, because we are going to award the SOI Award for the best lecture among our young ophthalmologists. Thank you. You have 4 minutes.
Good afternoon, everybody. I would like to thank Ms. Portaio and SOA for the invitation. So I'm going to talk to you about a study on blood flow velocity on various types of choroidal tumors. So, as we all know, A and B scan ultrasonography has been for decades widely used for the assessment of various ophthalmic diseases. Later, color Doppler imaging has also been utilized for the assessment of intraocular blood flow. The basic principle of the Doppler effect lies on the fact that when a sound wave is hitting a moving target, it gets reflected with a different frequency. This difference in the frequency is called the Doppler shift, and it depends on the angle of the wave meeting the target, as well as the speed of that moving target. Recently, with spectral Doppler techniques, we can apply the angle correction automatically, and we can calculate the speed of the moving target, in this case being the erythrocytes. So this is a retrospective study that was conducted in the Ocular Oncology Department of Moorfields Eye Hospital within 3 years' time, and we assessed the results of patients with intraocular tumors that had color Doppler imaging and B-scan ultrasound. This is the machine that we used, and there was an experienced ultrasonographer that conducted all the tests. And we had 353 cases of intraocular tumors with internal blood flow. 304 out of them had measurable blood flow velocity. It's counted in centimeters per second. 272 out of them were in the choroid, and 258 of them were among the 4 main tumor categories, namely 191 choroidal melanomas, 23 choroidal hemangiomas, 19 choroidal metastases, and 25 choroidal nevi. In these pictures, we can see the color Doppler imaging. We can see that the data are color encoded and superimposed on a grayscale image in real time. In this picture, we can see the Doppler shifts demonstrated as time versus velocity waveforms, and the maximum systolic velocity is being calculated as the mean value of the maximum systolic velocity over 5 cardiac cycles. This is a histogram showing the distribution of the velocities among all the tumors. As we can see, this is a non-Gaussian distribution, and for that reason, we have used the median values to assess our results. As you can see here, for choroidal nevi, the median value is 8 centimeters per second. For choroidal malignant melanoma, it's 10 centimeters per second. It's higher for choroidal metastasis, 15, and much higher for choroidal hemangiomas, 22. This is a box plot showing the distribution in all the tumors, and here it's again for each category separately. Here we can see the median values that we mentioned before. So for statistical analysis, we used non-parametric tests to assess the difference across all groups and separately to compare different groups. As we can see here from the p-values, there is strong statistically significant evidence of difference across all groups and between every pair, with the exception of choroidal hemangioma and choroidal metastasis. We also wanted to see if there is any correlation to the blood flow velocity and the size of the tumor. In this scatter plot, we can see that there is no correlation of the velocity to the height of the tumor. This is to every group, and the same goes for each group separately. We did the same for the velocity and the longest diameter of the tumor. There is no correlation between the two values. This is for all the tumors and for each group separately as well. So in conclusion, we can see that systolic blood flow velocity can be measured by spectral Doppler in choroidal tumors. Blood flow velocity varies significantly among the most frequent types of choroidal tumors, being higher in hemangioma and metastasis, and lower in melanoma and nevi. And this is a tool that can help us differentiate the tumor types, and to that helps the fact that there is no correlation of blood flow velocity to the size of the lesions in any group. Thank you.
Thank you very much, Dr. Kopsidas. Can Dr. Dimopoulos come up from Birmingham and Midland Eye Hospital? You have 4 minutes. 3.5, actually.
A bit more, please. Okay, yes. Thank you. Good evening. I will present you our experience with Avastin in diabetic macular edema. The study has recently published to the Clinical Ophthalmology. We all know that diabetic macular edema is the leading cause of vision loss in patients with diabetes. And we know that anti-VEGF therapy is beneficial in terms of visual gain and reduction of central retinal thickness. The NICE guidelines on February 2013 recommended Lucentis for diabetic macular edema, but only in patients with central retinal thickness above 400 microns. The decision was based on evidence from RCTs that found that only in those patients had more improvement. There are many studies in the literature regarding Avastin in diabetic macular edema with varying visual outcomes, and we found only one study to date that shown a greater response of Avastin, but the lower cost has made Avastin very popular. Our purpose was to investigate whether eyes with diabetic macular edema and CRT thickness more than 400 microns had better visual and anatomical outcomes compared to eyes with CRT less than 400 when treated with Avastin. We tried to answer the question, is there a need for a CRT cutoff in DME treated with Avastin? Avastin, we know, is cheaper, but is it effective in DME? It was a retrospective study that was conducted in a tertiary referral unit in a real-world setting. There were a lot of inclusion criteria. All patients had a full ophthalmic examination for the first 3 months. And after the first injection, the retreatment was performed if there was persistent macular edema, and eyes that had no response to Avastin had to have a rescue treatment with Kenalog. We analyzed many parameters, the number of injections, the visual acuity, and the CRT at baseline and at year 1. We divided the patients in 2 groups, those who had CRT less than 400 and those who had CRT more than 400. And all the comparison was done with SPSS. At the end, we had 175 eyes were included in the analysis. 81 eyes had CRT below 400, that was the group 1, and 94 eyes had CRT above 400, that was the group 2. Here you can see that both groups had the same percentage regarding the periretinal membrane or vitreomacular traction at baseline. Our results now. We found that group 2 had significantly more injections than group 1. Both groups had significant reduction in CRT at month 12. A reduction in CRT was significantly greater in group 2, and both groups had comparable visual acuities at the baseline and gained 6 letters at month 12. Here you can see with graphs our results. You can see here the reduction of central retinal thickness between the 2 groups, and also the gain of the visual acuity in terms of logmar units. We found one only study in the literature with Avastin in DME that is doing a subgroup analysis of visual outcome based on baseline CRT. Our results was the same with that study of Soheilan et al. And the only difference was that we found no significant difference between groups in terms of visual gain. And Soheilan et al. Found that the patients that had CRT below 250 microns had significant greater visual acuity gain. The reason for that could be that our patients had chronic DME, and the follow-up period at the other study was only to 36 weeks. We had also several limitations. It was a retrospective study. There were variable criteria for a treatment. There was no control group of Lucentis or other treatment. So the overall efficacy of Avastin could not be judged. However, the strength of this study lies in the consecutive nature of its fairly large series and unselected population. In conclusion, there was no difference in functional outcome on the basis of an anatomical threshold of 400 microns of CRT at baseline. If the CRT was thicker, the patients required more injections, so this could be potentially less cost-effective. At the end, our results could be used to support the use of Avastin in diabetic macular edema without applying a CRT cutoff. Thank you very much.
Thank you, Dr. Dimopoulos. Let's invite straight from Paris, Chrysanthi Basdekidou, to talk to us. Chrysanthi, you have 4 minutes.
I will only need 2.
That's great.
Okay, so I'm going to present you a case that really struck me. A 15-year-old girl, African but born in France. She came because she had a simple chalazion, excised twice, and she came to me. She arrived with this lesion on her right lid. So our hypothesis was like sebaceous carcinoma, Merkel cell carcinoma, although not really usual at that age. A low-grade lymphoma, an inflammatory disease, mostly sarcoidosis, or an histiocytosis. So we did a general workup that all came out negative, and then we performed a biopsy. Extemporaneous examination showed the benign character of the lesion, so we performed only a partial resection, and the results came out and gave an acute non-specific polymorphous inflammation. All went well, but 2 months later she came back, and this time not only she had the lesion on her right lid, but also a huge parotid mass together with a swollen cervical ganglion. Like, okay, so it's starting to getting a little bit more complicated. What shall we do next? So we performed an infectious workup, came out negative, and we said, okay, we'll do a new biopsy, enlarged this time with an extemporaneous examination and a ganglion biopsy. It showed us inflammatory infiltrates, and together with this, high IgG4 deposits. So we looked a little bit up the literature, and we found that indeed it exists. It's called a hyper IgG4 syndrome. It's a new lymphoproliferative disorder that encompasses every fibrous pathology with systemic sclerofibrosis. It can affect any organ, but mostly the glands, the lacrimal gland, the parotid, and the pancreas. Its characteristics, an IgG4 plasmacytes deposit on the different organs, and IgG4 increased level in the serum, and it responds very, very well to corticoids. So this is what we did. We put her on oral corticoids for 3 months, and you can see the final result. So next time you see a chalazion, just think about it. Thank you.
Thank you so much, Chrysanthe. So let's ask my co-fellow in clinic, Vasilis Georgopoulos, to come up.
Good afternoon. I would like to thank the organizing committee and all of you for being here this afternoon. My name is Vasilis Georgopoulos, and I come from Red Cross Hospital in Athens. Today, I would like to talk to you about an alternative treatment of an iris endothelial cyst. The case is about a 72-year-old male referred to us for an AMD investigation. His medical history included a benign prostatic hypertrophy, a chronic obstructive pulmonary disease, and hyperlipidemia. His past ocular history revealed only a penetrating injury with a pencil to his left eye as a child. Medications he's receiving was albuterol and a history of onychtokas. He did not have any known allergies. At the ocular examination, we found a visual acuity best corrected to his right eye around 30-36 and to his left eye 24-36. His intraocular pressure was 16 and 18 millimeters of mercury. He did not have any RAPD, and the motility was normal at both eyes. The confrontational visual tests were also good. At the anterior segment examination, there were no findings on his right eye, whereas at his left eye there was a clearly visible cyst at the inferior part of the anterior chamber. At the dilated fundus examination, the C/D ratio was normal, there were healthy nerves, macula and vasculature showed just some mild AMD signs, and the periphery was also normal. So, at the biomicroscopy, it was really hard to miss this quite big cyst at the lower inferior part. And at the right photo, one can also notice some pigmented cells. The UBM scan revealed the exact dimensions of the cyst that were 4.2 to almost 3 millimeters, covering, as you can all see, the inferior part. So the diagnosis that we put was that it is an iris epithelial inclusion cyst, which actually was a secondary iris cyst, because primary iris cysts developed during childhood and early adult life, whereas the secondary cysts develop after an event that causes an inclusion of endothelial cells within the iris stroma, which is usually a trauma. The secretions of these epithelial cells may enclave and cause these cyst formations. The cysts are always transparent, in contact with the endothelium, and sometimes can cause reduction of the visual acuity by blocking the visual axis, and also may cause signs of anterior uveitis, elevated IOP, and endothelial decompensation effect. Hence, they often need treatment. According to the bibliography and the research we did, contrary to the pupil cysts, these cysts cannot be treated with a YAG laser, since they always tend to reoccur within a week. So the standard treatment includes surgical removal, ethanol irrigation, needle aspiration, and ab-externo laser photocoagulation. The treatment that we performed was an alternative one, but still using YAG laser. Instead of punching a hole, we created a whole YAG capsulotomy, and the settings we used were around 10 shots of 2 to 2.5 millijoules. At the left picture, you can see we have started making the hole, and at the right picture, it's finished the hole, as you can also notice. During the YAG laser treatment, we did not face any difficulties, apart from the fact that after the first shots, when the cyst became mobile, it was quite hard to hit it because it was moving and it could not absorb the YAG laser energy. Post-treatment, the patient was administered a non-steroidal anti-inflammatory drug treatment 3 times a day for 2 weeks. During the post-treatment week, the patient did not mention any discomfort, and 1 week post-treatment, the IOP was measured at 19 millimeters of mercury with no significant signs of inflammation at the anterior chamber. This is the photo 1 week later. One can see that the opening is still well open. The cyst wall is a little thicker, and it has apparently diminished in size. 3 months later, the cyst is even smaller. The capsulotomy that we performed is even more enlarged with well-defined borders. The cyst has shrunk and deflated with thicker walls, as we mentioned before. It is considerably smaller and remains quite stable, restricted at the inferior part of the iridocorneal angle, as you can see on the picture. So our conclusions are that a YAG laser treatment of the iris epithelial cyst is possible indeed, but most importantly, it is a relatively easy, safe, fast, painless for the patient, and cost-effective method of treating an epithelial iris cyst. Thank you very much.
Thank you, Vasilis. Sofia Zogana from Polyclinic Athens is next.
Ladies and gentlemen, our presentation concerns a male, 75 years old, who came to emergency hospital due to left eye pain and blurred vision. As he mentioned, his post-ophthalmic history was free. Clinical examination showed the following. For the left eye, visual acuity, 5 to 10, non-improvable with pinhole, IO pressure 14, slit lamp findings, as we can see here. Cornea mutant fund participates, +2 anterior chamber cells, +1 flare. Also, he had nodule skep and Busaka on his iris, and posterior synechia and pigment on the lens, maybe due to older episodes of uveitis that patient did not understand. Vitreous was free of cells and without other signs of inflammation. Fundoscopy showed mild periphlebosis at mid-periphery, but no retinal granulomas. Further examination, US, OCT, RNFL were free. Concerning right eye, visual acuity 10 to 10, IOL pressure the same as left eye. The only abnormal finding of slit lamp was posterior synechia to a lesser extent than the left eye. Vitreous and fundus were within normal limits. From the above findings, the primary differential diagnosis was tuberculosis, sarcoidosis, Behçet syndrome, and CMV retinitis. Questioning of his personal medical history, we found that he suffers, except of coronary artery disease and Parkinson's disease, from sarcoidosis grade 2 diagnosed 3 years ago with biopsy under CT. Thus, the diagnosis was chronic anterior uveitis due to sarcoidosis. Initial therapy was topic steroids hourly, mydriatics twice a day, and double check in 48 hours. After 2 days, we had the same visual acuity, little reduction of pain, same findings in anterior chamber. So we did subtenon injection of triamcinolone alone. Double check in 48 hours showed recession of symptoms, visual acuity 7+, arterial chamber +1 cell, no flare, and unfortunately posterior synechia were permanent. So we did reduction of treatment, topical steroids 4 times per day, mydriatics 2 times per day for 15 days. That's a new image. After 15 days, we had total improvement. Visual acuity was 10 to 10, anterior chamber half cell. The treatment was continued for another 15 days, reduced by 1 drop per week. Currently, been 6 months since the patient first came to us. We examine him every 3 months. The monitoring is based on clinical assessment of cells and flare, and also on the evolution of his initial disease. In case of relapse, we will redefine the very first schedule of therapy, and we will discuss about intraocular or systemic steroids and also antimetabolites as azathioprine and immune modulators or biological blockers. Thank you.
Thank you, Sophia. Irini Hadjirali from Ophthalmological Next.
Dear colleagues, good afternoon. I would like to thank the organizing committee for the invitation to participate in this session and to present you a case report of retinal neovascularization in a young patient with sickle cell anemia, giving emphasis to diagnosis and treatment. Our case involves a 27-year-old male patient who presented to A&E department of our hospital with blurred vision in the right eye and floater since 3 days. His visual acuity was 3 to 4 out of 10 in the right eye and 10 out of 10 to the left eye. The slit lamp examination was normal in both eyes, as well as tonometry. And fundoscopy revealed a vitreous hemorrhage in the right eye and normal left eye, so he was referred to medical retinal department of our clinic. His medical history includes sickle cell disease. As you can see here in the infrared fundus photo presentation, we can see a great vitreous hemorrhage, with a sharp appearance, ended to a peripheral retinal neovascularization like CFAN, while the left eye was totally normal. The optical coherence tomography shows no retinal edema, while the fundus angiogram shows here the retinal neovascularization, the CFAN retinal neovascularization and leakage in these cases, with areas of ischemia as well as in left eye, and some retinal anastomosis. So, about sickle cell retinopathy, we know the pathophysiological mechanism, which includes hypoxia, producing hemoglobin S polymerization within the erythrocytes, and transformation into the shape of a sickle, reducing cell pliability. And this causes hemolysis and vessel occlusion. The principal risk shown in the eye was the peripheral retinal vasculature. We know that sickle cell may produce some manifestations from the anterior segment, like conjunctival lesions, iris atrophy, or potential rubeosis, while from the posterior segment, we can divide it in non-proliferative retinopathy, causing venous tortuosity, salmon patch hemorrhages, iridescent spots, or black sunburst. Or, like in our case, we can have a proliferative retinopathy, staged according to this classification in 5 stages. In fact, our case was stage 4 classification in the right eye and stage 2 in the left eye. And what about treatment? Spontaneous resolution can be present in 32%, and so no intervention is needed in small asymptomatic peripheral lesions due to auto-infarction. Treatment is needed when rapid growth of CFAN is present, or hemorrhage or bilateral proliferative retinopathy was present to prevent the vitreous hemorrhage or ended to stage 4 proliferative retinopathy. Treatment modalities include laser photocoagulation in ischemic areas, vitrectomy in non-clearing hemorrhages, and nowadays anti-VEGF agents shows promising results. So in our case, we offer the patient the possibility to undergo an intravitreal ranibizumab injection. 2 weeks after one injection, his visual acuity was improved to 7 out of 10 Snellen chart visual acuity, and the fluorescent angiography shows a regression of vitreous hemorrhage and the regression of neovascularization at the periphery, although the ischemia was remained. We can see here the other fluorescent angiograms with a regression of the neovascularization. We added the patient one session of laser photocoagulation in the ischemic areas. So 2 months after one Lucentis injection and one session of photocoagulation, we can see here the regression of the hemorrhages. Here is the laser spots. And the visual acuity was normal. So, in conclusion, when we searched the literature, there is only one case report about Avastin off-label use of Avastin for sickle cell retinopathy. So we have this case report as the first one using intravitreal ranibizumab, offering promising results in proliferative sickle cell retinopathy, presenting regression of vitreous hemorrhage and peripheral neovascularization, as well as improvement in visual acuity. Thank you.
Thank you so much. Is Dr. Klados here from Crete? So, okay, let's go on to Dr. Papalabros from Patras. So you have 4 minutes.
Okay, thank you. Thank you. I will present a case report for a polypoidal choroidal vasculopathy. It is a 73-year-old Caucasian man. He had deterioration of vision in his left eye, and from his previous ocular history, it was associated with AMD involving both eyes. From clinical examination, his visual acuity was 10 to 10 in the right eye, 4 to 10 in the left eye, and the arterial segments and the intraocular pressure were within normal limits in both eyes, and he had cataract in his left eye. From the infrared images, we can see in the right eye and the left eye the degeneration in macular areas. Then we done fluorescent angiography. In the right eye, we can see hyperfluorescent areas which reflect transmission defect due retinal pigment epithelium atrophy. And in the left eye, we have hyperfluorescent areas increases over time, reflecting ligands. This is the OCT from his left eye. We can see subretinal fluid and pigment epithelium degeneration. Our first diagnosis was dry AMD right eye, wet AMD left eye. Our treatment was 12 intravitreal Lucentis. After the 4 injections, we recommended our patient to do ICG angiography in Athens, and the results was that he had wet AMD. And after this, we continue with the other 8 injections. But the results, after 2 years, his visual acuity has declined in both eyes. We suspected for a polypoidal choroidal vasculopathy, and we advised to do ICG in our department. This is the images, fluorescent angiography and the Indocanyon green angiography in both eyes. We can see the hyperfluorescent areas in the fluorescent angiography in both eyes, and that we can see polypoidal lesions in early phases of ICG, and then we can see in the late phases leakage. This is the OCT in this time. We can see subretinal fluid and the retinal pigment epithelium detachment, and the subfoveal choroidal thickness is increased. Our new diagnosis was polypoidal choroidal vasculopathy. We done photodynamic therapy before 3 months. We have improvement in his OCT images, and now we continue with combination therapy. And this is now his OCT images. We can see the decline of subretinal fluid and the retinal pigment epithelium detachment. And finally, that we can say that PCV should be suspected in cases of patients who undergo treatment for wet AMD with anti-VEGF with poor results. And the ICGA is necessary for the diagnosis. Thank you very much.
Thank you. Dr. Triantafylla from Alexandroupoli. From? Alexandroupoli.
Good evening, ladies and gentlemen. This presentation aims to suggest an alternative to trabeculectomy surgical procedure using the Express Mini Glaucoma Drainage Implant. The Express device is a miniature stainless steel non-valved device with an external diameter of 0.4 millimeter and internal diameter of 50 or 200 micrometers. Its length ranges from 2.4 to 3 millimeters. It is proven to be safe up to 3 Tesla magnetic fields and doesn't seem to interfere in MRI imaging of the orbit. As it's shown in our hospital, we use the new P50 model as shown in the picture. Sorry. It is mainly indicated for open-angle glaucomas because in case of narrow angles, there may be not enough room to fit for the mini implant. It is not the best option in congenital glaucomas, although, because it is a new procedure and the concomitant use of antimetabolites may cause problems in the long run in these young patients. The initial steps of the surgical procedure are the same as in the trabeculectomy, up to the creation of the tract for the insertion of the mini implant. Specifically, we dissect the conjunctival and create a half-thickness scleral flap. Then we use the antimetabolites, which that depends on the surgeon's discretion, and replace scleral flap sutures. The Express is inserted at the blue transition zone between clear cornea and the sclera, area that corresponds to the calicunal meshworks. For this, we use a 25G needle. Then we suture the scleral flap and the conjunctiva. Complications include hypotony, ephema, and the device also may touch the iris or be obstructed by blood or vitreous. Young laser in these cases may be an excellent tool for removing the blockage. Antimetabolites themselves can cause also further complications like thinning of the sclera or the conjunctiva. As written in the literature, the Express device is at least as effective as trabeculectomy in terms of long-term IOP control and number of post-operative antiglaucoma drops. Furthermore, it has a lower complication rate, including less hypotony and inflammation post-operatively. In conclusion, we have ICT, anterior chambers OCT images. On the right picture here, it is the Express valve nicely placed in front of the iris. The aqueous flows and creates an episcleral lake and cysts on the conjunctiva. Although on the left picture, I don't know if it's clearly seen, the Express device here touches the iris. In cases like this, if the hypotensive effect isn't adequate or isn't symptom-free, then we should reposition the Express device. Thank you very much.
Thank you. Next is Dr. Tokos from Larissa.
Good evening to all of you. First of all, I would like to thank the organizing committee for this invitation. And I'm going to describe you a case of a 90-year-old man who was referred to the neurology clinic of our hospital due to gradual reduce of his visual acuity. The symptoms started from his left eye, and after about a week came bilateral. He was diagnosed elsewhere as an optic neuritis and treated so with a total amount of 4 grams of methylprednisolone. During the investigation, our neurologist performed all of the following exams: MRI of brain and orbits, CSF examination, visual evoked potentials, blood tests, and finally asked for ophthalmological and dermatological examination. When we first examined the patient, these were our clinical findings: a visual acuity of 6 out of 10 bilaterally, a normal intraocular pressure, no signs of inflammation, and a macular edema from the fundoscopy. This is the OCT of the first examination, and you can read on the right of your screen the macular thickness, 331 microns for the right eye and 406 for the left eye. The fluorescein angiography and ICG pictures, where we can see, a pinpoint pattern hyperfluorescence in both eyes, peripapillary. 4 days later, things became worse. His visual acuity was even more decreased at about 4 out of 10 for the right eye and 3 out of 10 for the left eye. There was inflammation, anterior uveitis, and a deterioration of the exudative detachment in the posterior pole. The new OCT images, with an increase of the macular thickness, it's about 977 microns for the left eye and 476 for the right eye. This is when we decided to start the treatment with corticosteroids with a dose of 48 milligrams per day orally. And in just a few days, there was a progressive improvement of the clinical presentation with a reduction of inflammation and macular edema and improvement of visual acuity. These are the autofluorescence and colored fundus photos just a few days after the start of treatment. Here you can see the exudative retinal detachments are still present. Some of the diseases included in our differential diagnosis: central serous chorioretinopathy, sarcoidosis, toxoplasmosis, intraocular lymphoma, NHL, acute multifocal placoid pigment epitheliopathy, Vogt-Koyanagi-Harada syndrome, and white dot syndromes. During the second week of treatment, these are our clinical findings. An impressive improvement of his visual acuity, 8 out of 10 and 9 out of 10 for the left eye, a decreased anterior chamber inflammation, +2, normal intraocular pressure, and improvement of the macular edema. That's the last OCT image. You can see the improvement here. So our goal now is to gradually reduce the dose of corticosteroids and gradually add immunomodulatory agents, such as mycophenolate mofetil. And since there were no neurologic, auditory, or indecumentary signs, we ended up to diagnose a VKH disease that is obviously probable since it's an isolated ocular disease. Thank you for your attention.
Thank you so much. And last but not least, George Kondavakis from Ophthalmiatria.
Last but not least, keep in mind.
Okay. So I will share you my experience from the emergency department. So it's Friday morning. We have it's 25 a.m. and after 27 patients with eye gum and floaters, there is a 35-year-old female with blurry vision and foreign body sensation and mild light sensitivity since 1 week in her right eye. She was diagnosed 5 days ago with herpetic keratitis, and she came to take the expert opinion of the resident in our emergency department in our hospital. So she was treated with topical acyclovir 5 times per day. Her best corrected visual acuity with her myopic spectacles was 20/32. And we could note at her slit rub examination, conjunctival injection, and a treating lesion in her central cornea. So our diagnosis agreed with her previous doctor, and it was Friday, so we told her to continue her treatment and come back in us on Monday. So after a nice weekend, we see her again as patient number 35 at Monday morning. She reports no subjective improvement. Her visual acuity was still 20/32, and her corneal sensation was within normal limits. In the slit trap examination, we can note that she still has a conjunctival injection. She has a central epitheliopathy, not this dendritic lesion that she had 3 days ago that we saw here again. So we think that maybe this is an improvement of her herpetic keratitis. But since we decided to take a closer look and we lift her upper eyelid, and as you can see, at the first, about 1 o'clock, at the anterior, one-third anterior part of her corneal stroma, there is this. I don't know if you can see it clearly there. This is a corneal nerve that has clear infiltration, perineural infiltration. So this seems to be a radial perineuritis. So now things change, and we don't have. It seems that we don't have a patient with herpetic keratitis. We have a patient who is a contact lens user, and she has an epitheliopathy and radial perineuritis. So our new clinical diagnosis is probably that she has a Cathamoeba keratitis. But the patient, she reports no pain. And this confuses the diagnosis. So we decided to perform a confocal microscopy of the cornea in order to confirm our diagnosis. So the confocal microscopy reveals that there are cysts and trophocytes typical of a Cathamoeba keratitis, mostly in her epithelium but throughout her corneal stroma. So it is Cathamoeba keratitis. We start treatment with PHMB and dosomedine hourly for 5 days, and then we slowly taper the treatment. The patient responds to treatment. 1 month later, her epithelium seems to be healthy. Her best corrected visual acuity is 20/20, but she still has stromal infiltration and some perineural infiltrates. And 4 months after presentation, she's still under treatment with both with PHMB and hexamidine 3 times per day. We also started a low dose of fluorometherone. Her visual acuity is 20/15. Her cornea is clear, and the confocal microscopy of the cornea, which was performed yesterday, shows that there is no sign of Cathamoeba keratitis throughout her stroma. So, this was a rare case of Cathamoeba keratitis with perineural infiltration that presented without any corneal pain and normal corneal sensation. What did we learn from this case? We learned that Cathamoeba is everywhere, in air, dust, soil, and water in our environment. We should always suspect Cathamoeba keratitis in patients that wear contactless, and especially when they are not very careful in cleaning them. If the diagnosis is made up to 3 weeks from onset of symptoms, then the prognosis of our patients is very good, and that we can always use confocal microscopy of the cornea to have an accurate and quick diagnosis, and also to follow up our patients. Thank you very much.
And now the best part of our session.
So I would like to invite Professor Seregard and Professor Taylor.
Give the word to Miss Foti. It's for you. Come up. Συγχαρητήρια. Ο κύριος Κοζομπόλης ζήτησε το βραβείο και εγώ φυλάω την βραβευτήσα. Μπορεί να έχω το μικρόφωνο. Professor Sergal, tell me, and Professor Taylor, your opinion about this session we have established about soy in Greece. Wait.
I think it's a great initiative, and 10 days from now we'll have the SOE board meeting with 45 representatives, and of course we will hold your example to the others and see if we can get 44 more new lectures across Europe.
Professor Taylor, what is your opinion about this session we have established in our Congress?
Well, I think the SOE is very important, and young ophthalmologists are very important indeed. They're our future, and so the two together must be a winner.
Τώρα θέλω να καλέσω όλους τους ομιλητές να ανέβουν να πάνε να πάρουμε μια φωτογραφία όλοι μαζί. Παρακαλώ γρήγορα οι ομιλητές να έρθουν να πάνε. I have called all the speakers to come up to take a photograph. And we have to decide which lecture, in your opinion, we have to award after the photograph. Έλατε. Σε έχω μπερδέψει τώρα. Σε έχω μπερδέψει, αλλά δεν πειράζει, εντάξει. Ωραία, κάτσε κάτω ψηλά. Sit down, sit down. Έλα, εσύ, Χρυσιρίκα, κάτσε κοντά μου εσύ. Εντάξει, εμένα κοίταξε. Ωραία, ωραία. No more photographs is enough. Now the best, what is your opinion about the best lecture? And after we have a good soiree for you. Please stay. Did you decide? Να πούνε ένα αριθμό περσές. The guy of the system. Okay. Ποιο είναι η ομιλία, Καβελού. Come up please with the small Uzo. Okay. Έχουμε μια ωραία, να πιείτε ένα ουζάκι για να ευχηθείτε καλή επιτυχία στα επόμενα συνέδρια. Και σας έχουμε μια ωραία μουσική και θα πάρει το βραβείο. Σίγουρα. Για ελεύθερα, ελάτε, μην τρέπεστε στον κόσμο.